Welcome to the Australian Prescriber podcast. Australian Prescriber, independent, peer-reviewed and free.
I'm Denali Pereira, your host for this episode, and it's a pleasure to be speaking to Dr. Catherine Davison. Catherine writes about optimal antimicrobial prescribing in general practice. Catherine, welcome to the program.
Thanks for having me.
Catherine, can you start by telling us what the consequences are of poor antimicrobial prescribing? Why do we make such a fuss about it?
Well, antimicrobial prescribing is actually pretty difficult, and I'd like to give kudos to anyone prescribing antibiotics because I find it hard, and that's basically all I do every day, although many times I don't prescribe antibiotics, but it is hard when you're faced with a patient in front of you. There are a number of consequences, which I think as practitioners we probably underplay a little bit. The first one that I worry about clinically is when I don't pick the right drug. So when I'm not following guidelines, we have a lot of literature now that shows that we actually choose much worse in terms of drug bug coverage. So we actually can have clinical failure from not picking the right drug for the bugs that are causing the most common infections. So clinical failures are a really big consequence of actually poor antimicrobial prescribing. Of course, one thing we go on about is adverse reactions of antibiotics, and for the patient that's really important. And I think personally, unless I'm asking that in every consultation, patients underplay and underreport it to us as practitioners. Diarrhea, antibiotic-associated diarrhea, is a significant adverse reaction that people underreport. We have about a 3 to 4 times increased risk of causing antibiotic-associated diarrhea with broadening our spectrum from amoxicillin to amoxicillin clavulanic acid. Thrush is a really significant adverse reaction that's quite disabling for people, and 7 to 8 times risk of getting thrush with antibiotics. One thing we do worry as hospital practitioners, which we see all the time, is Clostridium difficile associated diarrhea. The interesting thing about the adverse reaction of this type of diarrhea, which requires antibiotics itself, is as you increase dose, as you increase the combination number, and as you increase the days of therapy, this risk gets higher from about 2 times to 10 times if you've had 1 antibiotic course to 5 antibiotic courses within 60 days. So that sort of upscaling of antibiotics and increased duration does increase your risk. Allergies, of course, are something we always worry about. But the thing that we start to need to conceive within our therapeutic considerations is that of antimicrobial resistance. And certainly if we can narrow our antibiotics or reduce our antibiotic duration, then we have a possibility of reducing antimicrobial resistance in Australian society.
So those consequences really are multifactorial. It's not just one thing that we're worried about.
That's right.
And your article mentions some great do's and don'ts for best practice antimicrobial prescribing in general practice. Can you run through them for us briefly?
Yeah, so antimicrobial sort of microbiological testing is one thing that can be a bit hard to decide about when you perform it and when you don't, but certainly it's not indicated in every infection. Generally, standard urinary tract infections in the absence of a concern about difficult to treat organisms or previous antibiotics in recent times are not necessarily indicated. We'd always recommend using some type of guideline. And so generally in Australia, we really are very lucky to have the therapeutic guidelines or local available guidelines in many circumstances, and would suggest people attempt to use them where possible. And one thing that helps people to work out where to improve is actually by documenting the reason that we're prescribing, not only for the practitioner who's prescribing, but also patients see different general practitioners. And so it's nice to understand why we're prescribing antibiotics should they represent. And the duration is really important. The focus of the article is actually looking at the evidence of the shortest duration of antibiotic. And so making sure we're prescribing to the shorter end of the recommended durations, as opposed to extending antibiotic durations, can really help both the patient and society in terms of best prescribing antimicrobial. And the other thing is that we generally wouldn't advocate for routinely providing a repeat prescription.
Okay, some great tips there. And there are times when antimicrobials are not needed. Why is this the case? What are some examples, and where do prescribers go to get some more information and guidance on this?
So in primary care, it's really a balance about trying to work out which patient will benefit the most. And as we've talked about, the multifactorial considerations are really complex, I think. But in my head, when I'm thinking about prescribing, there are three main reasons I prescribe antibiotics when they're actually indicated. And we'll talk about when it's not indicated in that context. So symptom resolution is the thing that patients really worry about most. So when they come with the sore throat, they want it gone. And unfortunately for the patient, antibiotics actually don't really help much. So antibiotics shorten the duration of symptoms in a sore throat by about 16 hours, which, when you present that to a patient, that's not actually that much time. So we also prescribe for bacteriologic cure. So when we're dealing with pregnant ladies with urinary tract infections or those undergoing a urological procedure, bacteriologic cure is actually more important. We like to eradicate meningococcal disease from someone's throat. That's really important. And the other thing that we worry about is the reduction in complications. So conditions where antibiotics are not necessarily required in mild disease particularly are things like the acute sore throat, where viral causes are more likely in many situations. Acute rhinosinusitis, in the mild situation, there's not a lot of benefit. As you get more radiologic features or severity, there is some more benefit.
Okay. Now, your article does mention 4 great strategies to assist with optimal prescribing: the watch and wait method, to prescribe but maybe not dispense yet, to specify durations that don't have to match the pack size, and changing default prescribing software to have a no repeat rather than defaulting to repeat. Do you mind just really briefly just touching on these little 4 strategies?
Yeah, sure. So the watch and wait and the prescribe but not dispense could be sort of packaged together, and it depends on your patient in front of you whether you think they'll be able to come back or what their preferences are as to what you might suggest for them. Watch and wait obviously is seeing how the patient goes and asking them to come back if things worsen, because in that situation things may be more likely to be bacterial and require antibiotic therapy. Prescribe and not dispense is where you give a patient a prescription but say, really don't go out today and fill that at the pharmacy, but wait a few days and see how you're going. And that's really shown to have the similar patient satisfaction scores and actually decrease the antibiotic use quite considerably from about 90 to 30%. And specific durations, for example, cystitis, in uncomplicated cystitis, 3 days is only required, but the pack size is 7. So actually detailing the duration as opposed to just saying the standard pack size can actually reduce antibiotics in the community. And the no repeat default can be changed in various IT systems, and it can be a good strategy to stop that automatic entering repeats when you're prescribing for patients.
Yeah, okay, great. In general, Catherine, is there much evidence to support the efficacy of shorter courses of antimicrobials?
Yeah, there is a lot, and certainly this literature has evolved over the last 10 to 20 years. So if you just take things such as urinary tract infections, 3 days has been shown to be beneficial in many circumstances as opposed to 7. When we're prescribing for pharyngitis, of course, most of it's not required. Short course therapy has been shown to improve symptoms 5 days compared to 10 days, but we still prescribe 10 days because we're trying to decrease those complications in those higher risk patients. And otitis media, short courses of less than 7 days have similar outcomes to longer duration in therapy with children. And even mild community-acquired pneumonia, actually 3 days in children has been found to be no different to 5 days. Therapeutic guidelines currently recommends 5, but our Australian and New Zealand Paediatric Infectious Diseases group have actually recommended decreasing this to 3 days. And acute rhinosinusitis, something we were talking about before, the shorter course, 3 to 7 days, has shown no difference to 6 to 10 days of the sinusitis resolution or microbiological efficacy and relapse. So lots of data there to support shorter course prescribing.
Okay, fantastic. So there seems to be a recurring pattern of specific populations where a shorter course may not be appropriate. Can you tell us a bit more about these populations?
Yeah, and this is the other thing I think about when prescribing is about patient risk. That as we can segregate people into high and low risk based on various sort of characteristics, we can be more comfortable in prescribing and not prescribing. And a example of this is a patient population with high risk of complications of Group A strep in sore throat, and that's the Aboriginal Torres Strait Islander group. So we're prescribing really to prevent complications, and I touched on that before in that the shorter course is actually for symptom resolution, but the longer course, we haven't shown that a shorter course reduces complications, so we still recommend a full 10-day course to prevent complications in Group A strep pharyngitis. And urinary tract infections is a similar one in pregnancy. The shorter course is shown to reduce symptoms, but actually microbiological eradication, so stopping growing the bug in the urine, is more beneficial at 7 days. So we have longer courses in pregnancy and those undergoing urological procedures for urinary tract infections.
Yeah, sure. So both health professionals and patients historically have been drilled about always completing their course of antimicrobial, even if they feel better. And some patients really do follow that diligently. But there are some exceptions to this rule. What are they?
When we're giving someone antibiotics and we're really not sure if it's bacterial or not bacterial, it's often not bacterial, and so we can safely stop antibiotics and people don't have any problems. But when we are sure we're treating a bacterial infection, then we still would suggest people complete the exact amount of days that the doctor recommends. And this is different to the pack size. So you don't necessarily need to complete the whole pack, but if we are treating a defined bacterial infection, then we would recommend the days that is prescribed by the GP.
Wonderful. Well, that's unfortunately all the time we've got for this episode. Thanks for joining us today, Catherine.
No problem. Thanks for having me.
The views of the hosts and guests on the podcast are their own and may not represent Australian Prescriber or NPS Medicine Wise. I'm Danelli Pereira, and thanks for joining us on the Australian Prescriber podcast.